The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, with the part of this that's kind of fun where the people out there who are listening get to send in questions. We have several questions, and Jeremy Hendrick is kind enough to have come back to answer those questions, because otherwise I would have been left hanging just sort of speculating about all this stuff, and that would not have been helpful. So welcome back, Jeremy.
Thanks for having me back. I was a little worried you wouldn't invite me back, so this is saying something.
Very unlikely.
Questions, that's a good thing, right?
Very, very, very unlikely. Do you have any disclosures?
No disclosures today.
Any personal stuff about yourself you'd like to share?
Well, we were talking about disclosures before we recorded, and I was thinking I needed to disclose a cookie incident from my early childhood, but we'll leave that to the side.
And I thought you needed to disclose your astrologic sign and whether or not you enjoy watching a sunset. All right, we have a bunch of questions, so let's dive right in. Brace yourself. Okay, question number 1. First couple of questions come from the inimitable Lulu Waterhouse, who always asks great questions. So number 1. It seems that several of my patients see a mental health professional and get put on lamotrigine as a, quotes, mood stabilizer. These patients don't meet criteria for bipolar disorder and honestly seem like teen girls going through a lot of stress, drama, and anxiety as teens deal with these days. Can you speak to the use of Lamictal in teens, especially when there's no indication of bipolar disorder?
This is a great question. Lamictal is definitely one of those medications that gets utilized in tough kids, probably a lot because of some of the adult data we have. Lamictal is traditionally prescribed as a mood stabilizer. So, Dr. Waterhouse's point about bipolar disorder is an important one, and it is a medication that's often used for treating bipolar disorder. Lamictal and mood stabilizers in general do actually have quite a bit of data as just augmenting antidepressants regardless. So I imagine that what these providers are thinking is that they have a patient who is not being treated as successfully as they would like with monotherapy of an underlying antidepressant. And so lamotrigine might be added as an augmenting antidepressant there. That just speaks to the fact that a lot of our mood stabilizing medicines do really help just augment the antidepressant effects of SSRIs. The other point embedded in there, though, was the fact that if you have a clinician who really recognizes that a lot of what the distress the patient might be experiencing has a lot to do with just kind of normal teenage stuff, I think that really speaks to the importance of understanding the biological, psychological, and social components of depression. And if you have a patient who's getting lots of medications and not getting better, but they have a history of trauma, they have a lot of stress at school, they're getting bullied, all these other things, that probably speaks less to the ineffective nature of the medications and just more the fact that we're not treating kind of the most important things for that patient. So, in patients like this, where there are a lot of external stressors, I think focusing on those, making sure they have good therapeutic support. But the point about lamotrigine is it is not just used for mood stabilization in the sense of stabilizing between a depressive episode and a manic episode, but these medications, these mood stabilizers, can be added to a primary antidepressant to kind of augment just the antidepressant effect, even in a unipolar depression.
And typically as an augmenting agent, not monotherapy.
That's correct. Lamotrigine does have an indication just for depression, more so in adults. That is not something that's really been shown to be the case in kids, and it's pretty much off-label use for depression in kids. But I would say I would question the use of lamotrigine as monotherapy for unipolar depression.
Very helpful. You ready for another question?
You bet.
Here comes another one. I feel like I've heard from psychiatrists that buspirone is not much more effective than Tic Tacs, but I know a provider who swears by it when dealing with anxiety and isolation. That is, no depression or ADHD. She says it works wonders for her and has seen it help some of her patients. I've heard it can be used as an adjunct, but usually not as monotherapy. Thoughts?
Boy, buspirone is one of these medications that you do get a lot of like clinician kind of experience and opinions about. If you look at the literature, if you look at the data, especially in kids, there's not as much in kids as there's in adults, but really buspirone does not separate from placebo in many kind of clinical trial type studies. It's been looked at in a couple of different areas, specifically for anxiety, but also in some other conditions like ADHD and other types of things. And just more often than not, it just doesn't separate from placebo in those studies. And so that's where it gets kind of, I think, its reputation as being a quote unquote placebo or a tic tac. That said, I absolutely have had patients for which we have gone through a lot of what I would consider more first line options. And I have prescribed it on rare occasions with mixed success. Again, I think at the point that you have a provider who really swears by it, I think understanding the situations in which that provider is using it, I thought it was interesting that this question pointed out that this is not in patients that tend to have a lot of comorbid other diagnoses going on. So, I think understanding that prescriber's kind of situation where they're using it might help inform ways in which you might want to use it. I will just say for me personally, I just haven't found it as effective as I would like, but I still see it prescribed quite a bit by a lot of folks who really do think there is a role for it. I do think that it tends to be much more helpful for primary anxiety symptoms. And my experience has been that it's more successful when it's augmented on top of a first line anxiolytic like an SSRI or something like that.
Can I ask you a couple of brief follow-up questions on that?
Yeah.
First follow-up question is, it would seem like one of the biggest difficulties in evaluating efficacy is that it's not like you can do a lab that says, this is how much you're better. And it would seem to me that to some extent, a placebo effect would be enhanced by being given that potential placebo by a true believer. Do we have any data about that? Do you know?
Absolutely. I mean, this is such an important such an important thing in psychiatric practice. We oftentimes talk about the placebo effect as being this kind of negative thing, like it means nothing.
Yeah. Yeah.
But in psychiatry in particular, like we embrace the placebo effect. I mean, that is basically, the therapeutic kind of impact that we can have in the way we show confidence about the treatments we're doing, those types of things. So yes, and I'm really glad you asked that follow-up question because I did have that thought in the back of my head. The fact that this particular provider really sounds like experienced themselves or some relief themselves, but also has had other patients. I mean, when you tell a patient that they can expect to experience something, the likelihood that they will experience that is higher than if you wouldn't have said otherwise. And so we know this to be the case. We don't excuse away the placebo effect. We embrace it. If you look at any given antidepressant, they're only about 30% effective, but you have to remember that they separate from a 15% placebo response. So I don't necessarily have any problem with any intervention. When a patient comes to me and says, my naturopathic provider suggested X, Y, or Z and said it could be doing this, I can go do a lit search and see absolutely no separation from placebo. But as long as there is no kind of negative impact, if it doesn't propose, if there's no risk associated with it, I see no reason why a trial of that would not be something worth looking into. So I'm a big fan of the placebo effect.
Second brief follow-up. If you use Tic Tacs as a placebo, do you prefer the minty or the fruity ones?
Well, orange is by, I think that has actually been clinically proven to be the superior flavor of Tic Tac.
Okay. All right. Although less good for that not so fresh feeling in your mouth.
That's true.
Question number 3. You touched briefly on the notion of parental anxiety influencing anxious feeling in kids. There seems to be a lot out there these days about a highly structured / protective parental style contributing to the increase in anxiety in kids. Do you have thoughts about that? What should we recommend to parents about parenting styles? And does approach to treatment of these kids need a different approach than to free-range kids? Is there a, quote, anodyne-informed care as a correlate of trauma-informed care?
I really love this question. I love this idea of anodyne-informed care. So lots of layers there. I think the first layer is yes, parenting strategies and styles absolutely can affect and inform kids' views of the world around them and everything, which absolutely does feed into mental health. I think that we spend a lot of time as clinicians trying to help parents strike this balance between being under responsive and kind of these free range type kids that we're talking about versus the helicopter parent who is constantly there. And developmentally, it is very appropriate for kids to learn things like decision-making skills, being able to be faced with a conflict and not have it be solved for them, to learn how to deal with some of these things, deal with distress. And I think the number one kind of area where I see this in my clinical practices when I've worked in day treatment settings where, the kids are at home at night with their family and they're back with treatment with us the next day. And it becomes very clear that parents just don't tolerate their kids being in distress. And I think that's a natural thing. I say that as a parent myself. Mm-hmm. And so that urge to swoop in and solve an issue probably doesn't necessarily serve your child's best interest as far as helping them develop into an independent adolescent and adult. So yes, I think there is a balance to be struck there. And as far as treatment approaches, I really do think it has as much to do with trying to gently help the parent understand why they should consider a slightly different approach than any way of handling the kid. I think, we do so much parent training and education, specifically in anxious kids, because there is so much you can do as a parent to help guide and influence the development of some of these really important coping mechanisms that will serve them very well.
Is there a magic window for that? Is there a too early, too late to encourage people to let their kids work things out?
I don't think there's a window. I think the situations in which they might have the capacity to figure out absolutely will evolve and change. I mean, when your toddler comes to you crying because they're hungry, you don't necessarily expect them to go make themselves some mac and cheese. I think the types of situations in which we would push kids to try to come to solutions themselves change as they develop and grow. But the opportunities for parents to step in and kind of short circuit that process happen well into kids turning into adults. And that adult transition can be especially hard for kids that have not had the opportunity to experience some of those lessons growing up.
Yeah, very helpful. And as a parenthetical, the book that I'm going to be discussing with Angela Giardino at the end of December is going to be Jonathan Haidt's book, The Anxious Generation. And he talks a lot about this sort of stuff.
That's great.
Ready for a can of worms? Question: how should I deal with phones and my patients? It feels like they increase anxiety and isolation as well as distraction just as a device. And then when you add social media and predictive algorithms, it feels like we've become, both kids and adults, a large group of pigeons addicted to and potentially traumatized by our Skinner boxes. Does it help to recommend parameters? Are there data to suggest that this helps? Are there any TikToks describing how much better we'd all feel without our phones? And I like TikTok. We've now used Tic Tacs and TikTok in the same Q&A, and I'm hoping for sponsorship from one or the other.
It's interesting. I just got back from the annual meeting of the American Academy of Child Mental Psychiatry, and one of their noon meetings was a debate. It was actually a debate between a group of people talking about the question was, did social media cause the mental health crisis? You can look, and around 2009, 2010, the rates of mental illness and symptomatology really started picking up exponentially compared to the path they had been on prior to this. And this really corresponds with cell phones and social media and screens. And so, a lot of people will make the argument, social media is to blame for this, phones are to blame for this. And there were a lot of discussions back and forth, but I think the answer that kind of came out of that debate is it's very difficult to draw causality between these things, but you also would be ignorant to not recognize this pattern. And so, as with all things, I remember in my peds residency, like the biggest thing you had to worry about was, no screens between 2 years old. It's like,
right.
like things have gotten so much more.
Don't have a TV in your bedroom.
Exactly, right? Yeah. And so I struggle with this as a parent of a 14-year-old myself. I think the most important thing is having open communication about this. I think it's less about limiting Well, I do think there's absolutely benefit to having parameters around how much screen time is utilized during a day. So yes, I think having limits. I'm a big fan of utilizing the phone as a privilege as opposed to, a right. And so, phone access should really be contingent on function and behavior. And if kids are, getting their homework done and making good grades and doing the things that they need to do, then that's great. If not, and the phone is a big part of that, I think using that as something to limit so that they have more ability to focus on these more important tasks, I'm a big fan of that. But I do think that there are things that can be really looked at as far as communicating with your kids about media safety, all these types of things. I'm a big proponent of making sure parents follow their kids and vice versa on social media so they can kind of see what they're posting. But also kids want their privacy. And so having a conversation saying like, I'll follow you, but I promise not to comment on all of your posts. And I think as the technology becomes more nuanced and more kind of sophisticated in the potential stumbling blocks it elicits, it's going to be more and more important for us to just have really open communication with our kids. And so I think the communication to me is the most important thing. And absolutely, as a parent, having limits and boundaries around it and trying your best to try to strike a balance between setting limits, but also giving your kids some autonomy to figure things out and make decisions and live with the consequences of those decisions. And again, I say that as a psychiatrist, but as a parent, I would love some advice from people who know more than what I'm talking about.
Well, it's striking me because within just the past few days, I had one just terrific kid in a terrific family. But why are you not sleeping at night? Because I'm up on my phone till 3 a.m. And I said, get your phone out of your room. Your phone should charge somewhere else. She said, I would melt down. I thought, well, and then you'll recongeal and be fine.
That's such a good point. We run into these situations with kids who will come into like a higher level of care, like something like day treatment. But I have had kids be admitted to an inpatient psychiatric facility for no other reason other than parents finally got to the point of setting a limit. And yeah, at the point that a kid has had free reign on this stuff and you set that limit, there is going to be some pushback on that. And I think that's where parents really have to, coming back to the point we made previously, that's where parents really do have to be able to set limits and hold those boundaries. Because yeah, there is going to be an extinction burst where you're going to get all sorts of interesting behavior. But once you reestablish a norm, then it becomes the norm. And I think, yeah, having phones at night in a bedroom, not a great idea. I think I've seen a lot of families even just making that one rule. Phones stay out to charge outside. That can make a world of difference in so many different areas. Sleep, notwithstanding, being one of those big ones.
Yeah. I mean, the other thing that happened a couple of days ago is I was having a mental health visit with a kid, and he was on his phone, and I stopped talking, and after a few minutes, he looked up. He said, "What? I'm just texting." But I think we're in a position where we've kind of surrendered to the idea of multitasking, and nobody's fully present anywhere.
Right. I think that's only going to get more difficult as time progresses. This technology is going to continue to advance. Before long, we're all going to have smart glasses and we won't even have phones anymore. And you'll never be able to tell who's on what, when. And so I think teaching kids, pretty fundamental social kind of skills around media use and device use is a real important kind of part of them being able to have these devices. I think helping guide them to learn those types of things, because again, they're growing up in a generation where there never was an alternative. This is just their reality.
The thing that I think makes it more challenging is I think that as adults, we're also trying to figure out how to navigate this.
Right? I think that's the funny thing. You can tell your kid to put the phone down at the table, but you better make sure your phone's down at the table as well.
Right, yeah, exactly. All right, question number 5 from Will Edwards. In the discussion about adding bupropion to an SSRI, you mentioned you do not change the dose of the SSRI. You did not comment on how you dose the bupropion in this situation. Do you use a standard dose or do you use a smaller dose?
Yeah, great question. I find the whole start low, go slow moniker of medications is even more important when you're dealing with polypharmacy. It's one thing when you're starting on a single agent, but if you're augmenting an existing agent, starting at a very low dose and moving up slowly is important. Bupropion in particular, I don't tend to use the standard release formula. I tend to use the extended release formulation. Just find it easier for kids and to remember dosing and everything. When you use extended release formulations, a little harder. You can't necessarily cut down the dose too much. So I will start with the 150 milligram extended release for most of these kids, but I will stay at that dose for a significant amount of time before starting to titrate any further.
Does the side effect profile look different in polypharmacy?
Oh, absolutely. And it gets hard because at that point, you could have two meds that are interacting against each other to generate a side effect that neither of those drugs on their own would cause. And so, I think that's another reason to just be very careful of when you're starting and stopping medications. Because not only if you start two agents at the same time, not only is it really hard to tell which one was helping, but at the point that you get a side effect, it makes it a lot harder to tease that out. So I think stepwise approaches in prescribing are really important.
We'll come back to this in just a minute, but that's the sort of scenario where talking to somebody like on a call-up line might be helpful.
Absolutely.
All right, we're coming back to that. Question number 6, I've always been taught to consider weaning an SSRI when treating depression after 9 to 12 months of a good response. Having said that, many children and their parents seem hesitant, even after a year of minimal symptoms, to try weaning the SSRI. It seems often one of the parents has been on the same SSRI for years with no plans to wean. Sub-question number 1, in patients treated for depression, is weaning an SSRI after 9 to 12 months of good response something we should strongly encourage or just offer?
This is such a good question, and I think it speaks to just how amazing pediatricians are. They follow these kids over their development. They're constantly thinking about those symptoms over time. And so my personal feeling is, especially in kids and adolescents, it's really important to reevaluate your treatment plan on a fairly regular basis. That has a lot to do with developmentally, they're going to have a completely different psychosocial stressor profile as they age. And the burden of those symptoms will change as they age and mature. And so we know that the medications are really only serving us in treating the biological component of illness. And so if you have a kid that you start on a medication that has a relatively high burden of those psychosocial stressors, and you see them after a year or so, age into a different situation where those psychosocial stressors have really calmed down, yes, I think it's a really great idea at that point to look at a med titration. That said, if you have a kid who really didn't have a lot of psychosocial stressors and the biological component of their depressive illness was, so significant that it was causing problems and you really felt they did better on a medication, that's kind of a scenario where maybe I would, have a little bit more pause of tapering that kid off, because the risk there is that you potentially bring about a symptomatic relapse. But there's just so much in child and adolescent development that influences mental health that I think a constant reevaluation of our treatment strategies is really important. When an adult is stable on a medication, I'm much less likely, short of there being a lot of these same psychosocial stressor type situations. But you got to remember, adults, their brain development is pretty much done. And so the effect of an antidepressant, you would expect that to persist over timeframes that are much longer than what you might want to reevaluate with younger patients.
Question number 2, do you try to wean a second time if a person fails the first wean? For instance, 12 months later, do you reconsider weaning again?
Yeah, I mean, I think at the point that they fail a wean, if bringing the medication dose down causes some symptomatic relapse, then I'm much less likely to say after another 12 months, like, oh boy, we should try this again. That said, after a few years, and it all depends on when we're starting these medications. If you're starting an SSRI on a prepubescent patient and they've transitioned through puberty, boy, the whole landscape, biochemically has changed, and I think reevaluating at that point. But if I have a teenager that did really well on a medication, we tried to taper off and they did poorly, I'm usually not approaching a re-taper of that medication for quite some time.
Are there data to suggest it's safe to use them long-term in developing brains?
What I will say is that the long-term data with SSRIs there has been no data that has come out that has us worried about their long-term use. Now, that said, that does not necessarily mean that there is a lot of data out there speaking to this. And so, could there be something long-term out there that we haven't asked or figured out? Potentially. But I remember I had a supervisor at one point say, I feel like this is like fluoride. We need SSRIs in the drinking water. Just speaking of the fact that the side effect profile for the most part can be fairly benign, short of some, pretty significant side effects that can affect individuals, especially into their adult years. So yes, I think the risk of treating a patient long-term with a medication that keeps them from having a brain depressed is much less of an issue than leaving their brain in a depressed state. We do have a lot of good data to show that it's just not good for or healthy for developing brains to be in the midst of depressive episodes.
Excellent point. Sub-question number 3, what are recommendations about weaning SSRIs after a good response in children with anxiety, OCD, or DMDD?
Yeah, I don't really separate these out from what we just talked about, the depression, too much. I mean, I will say in OCD, there's so much about OCD that is affected by good, solid treatment, doing exposure response prevention therapies and these types of things, that if I've started a kid on a medicine because they're just doing very poorly and they really develop a lot of good, healthy skills through therapeutic interventions, I might reevaluate the need for medication or dosing. But a lot of these kids are so severely affected that, again, the risk of a taper and having them in a relapse state is high enough that you have to balance that against the potential side effects of them just remaining on the medication longer term. But I think with any young patient, at the point that you've had a really good, solid period of stability, I think it is absolutely worth raising the point that maybe things have changed or evolved to the point that kids could do better or do well even without the support of the medication.
All right, last question. This is Will Edwards speaking, I think, for very many of us. Question about the call-up line, but first a shout out, amazing service, very grateful for it. My question is there an age limit for the patients we can call about? Not infrequently, 18 or 19-year-old patients will come into my clinic. Is your service allowed to consult about children in that age group?
You bet. We do, the child adolescent psychiatry faculty take any consult that comes in from a primary care provider up to 24. So we'll be talking about kind of developmental, kind of younger patient stuff with our child adolescent folks up to 24. We actually do take consults for older patients as well. It's not something we widely talk about because this is really a pediatric mental health care access program, but we know that there are adult providers out there who need support as well. And so we're kind of growing. I think the goal of a program like this would be to provide consultative support across the lifespan. But we really are very well geared up to handle consults for any patient up to 24 years of age.
And describe again how the process works.
So any primary care provider out there in the state of Utah who has a patient that they are interested in trying to get a second look or some support or bounce some treatment planning ideas off of, they can call the call-up line, which currently runs Monday through Friday, 12 to 4:30 p.m. And that phone number is 801-587-3636. After the first of the year, we're launching an expansion of the program, and those consultation slots will be available all day, Monday through Friday. And we're going to be launching a new web platform where busy providers who can't necessarily be on a phone in between and they would just rather exchange some messages back and forth, we're going to be launching a new web platform that will allow for some asynchronous consultative discussion. So look forward to launching that. But yeah, we would welcome any call from anybody out there looking to chat about their child adolescent patients.
Absolutely invaluable. One other thing, I think I mentioned this before, one thing that has worked for me too is you can call and make an appointment and say, I'd like to talk to somebody about 12:30, which has also been very, very convenient to try to work it into my clinic day.
That has been our goal all along. We know how busy providers get during the day. So anything we can do to kind of squeeze it in any of those empty spaces, we would love to help out.
All right, Jeremy, thank you so much for spending some time with us this month. I hope we can talk again sometime.
I'll look forward to it.
For all of you listeners out there, please like and subscribe because, as always, I'm very, very insecure and need to be liked. But that's also the only way that people find out about the podcast. And tune in next week for another set of episodes. Thanks, Jeremy.
Thank you.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.